SmithKline and French Laboratories is pleased to bring you this premiere edition of the 1986 Psychiatry Audio Cassette Library. Our series starts with highlights from the 7th Annual Vail Conference of the Menninger Foundation. Update on schizophrenia. Dr. Samuel J. Keith begins this program with an overview of schizophrenia, 1980s. Dr. Keith is Chief of the Center for Studies of Schizophrenia, National Institute of Mental Health, Rockville, Maryland. First, here's a brief message from SmithKline and French Laboratories and SK&F Co.
The fragile shell of the borderline patient. Like the shell of an egg, it may be seamless, secure.
Your borderline patients may manage a career, family relationships, rewarding friendships, until the pressure builds. Pressure to the point of overwhelming stress.
Then the fragile shell may crack. Psychotic symptoms emerge.
You can help return your borderline patients to reality by controlling emerging psychotic symptoms with the short-term use of non-addictive stelazine, brand of trifluoroperazine hydrochloride. And because stelazine seldom causes excessive sedation, your patients will remain more alert to other forms of therapy. Stelazine offers a convenient, economical BID dosage regimen that helps ensure compliance.
When the fragile shell of the borderline patient cracks, remember, stelazine controls occasional psychotic symptoms.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions, such as pseudo-Parkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. Now here is Dr. Samuel J. Keith with an overview of schizophrenia in the 1980s.
What do we know about schizophrenia that we didn't know 25 years ago? Is our ignorance of this disorder as profound now as it was then? We've seen our fantasies for a simple explanation for schizophrenia, from circulating psychotogens to food allergies, all fall victim to good research. Not that this need for a simple explanation for schizophrenia has totally passed from our fantasy life. Only too recently, hemodialysis and beta endorphins as treatments for schizophrenia have graced the pages of our most prestigious journals. Today, for example, we have the dopamine hypothesis and the stress diathesis hypothesis of schizophrenia. Both are long-standing, frequently discussed, and probably represent some of the better thinking that we currently have. We should be aware that until we fully explicate these hypotheses, they are only hypotheses and not new knowledge per se about schizophrenia. It's possible to reorganize the current diagnostic system into three basic interlocking components. A significant attempt at this was initially presented by Strauss, Carpenter, and Bartko back in 1974. Drawing from the work of Hewlings-Jackson, they presented a rather compelling argument for there being three groupings of problems associated with schizophrenic symptoms: positive symptoms, negative symptoms, and disorders of interpersonal relationships. By positive symptoms, they referred to those which characterize schizophrenia by their presence, the hallucinations, the delusions, the thought disorder. By negative symptoms, they refer to those which characterize it by their absence, the lack of goal-directed behavior, the blunting of affect, the verbal paucity. By disordered interpersonal relationships, they refer to the patterns of asociality, withdrawal, and lack of close personal ties, which seem to dominate the lives of many people suffering from this disorder. If we begin to look at the symptoms of schizophrenia as not being sacred, but rather as useful means of restructuring our knowledge base, can we continue this further by looking at other means to classify the disorder? The past 2 decades have presented us with an array of findings which would support the concept that schizophrenia may be a disorder with multiple etiologies, with a common symptomatic expression. No single factor, multiple factors, or even grouping of factors has ever been found in all schizophrenics, or only in schizophrenics. If we accept that this may be a possibility, that may provide us with strategies which may be more productive. Diagnosis should not achieve a status that really transcends its own utility. This is not to say that diagnosis should be ignored. The current DSM-3 is a major step forward in achieving reliability of diagnosis. Unfortunately, reliability has not brought validity with it, in part, perhaps because of the heterogeneity of the disorder. The continued attempts to narrow the diagnosis of schizophrenia as a means to develop greater diagnostic purity have thus far not been successful at all. And I'd like to briefly outline what kind of psychosocial factors are relevant to schizophrenia, why they are relevant, and how our treatments can potentially respond to them. We've proposed that there is overwhelming evidence supporting the role of neuroleptics in the alleviation of positive symptoms of the disorder. Almost no one would question the role of medication during the acute psychotic state. 80 to 90% of patients who have psychotic symptoms will respond to the use of neuroleptics with a reduction of symptomatology. Now, while there's consensus around this particular point, the strategies to be invoked around the treatment of acute symptoms have produced considerable disagreement and clinical opinion unsupported by research data. In discussing the treatment of positive symptoms of schizophrenia, it should be important to note that recovery from positive symptoms is not synonymous with recovery from schizophrenia. Unless new drugs are found which alter negative symptoms and improve social relationships, and not just creating a baseline condition without which improvement may be impossible in these areas, we shall need to rely on other interventions to bring improvement. It is here that the utility and refinement both of medication strategies and of psychosocial factors and their role in interventions must be considered. Standard antipsychotic drug treatment is well established as an essential component in the prevention of relapse for schizophrenic patients in the community. More recently, attention has turned to alternate drug treatment strategies to provide the advantages of medication while decreasing the risk of tardive dyskinesia and the occurrence of other side effects of neuroleptic drugs, such as akinesia. A further goal of the reduced dosage strategies has been the improvement of social functions. In a report, Dolores Kreisman and Dick Blumenthal found that low-dosage patients who did not relapse were rated significantly more favorably by their families than either the low-dose patients who did relapse or the standard-dose patients who did not relapse. Although the low-dose group required more supplementary medication, the type of symptoms they manifested rarely required hospitalization and was usually treated in the community without resorting to a return to hospital. As research continued in psychosocial factors, promising results began to develop in the areas of environmental interactions. Initial evidence for the impact of both institutions and impoverished social environments showed a dramatic impact of the non-stimulating milieus on the production of negative symptoms. Recently, interest in the environmental impact on positive symptoms has been stimulated by concern over the substantial relapse rates, certainly one indication of the return of positive symptoms, found in patients for whom medication compliance could be guaranteed by injectable neuroleptics. Explanations potentially could still relate to medication factors, rapid metabolism, clearance, or another as yet unspecified phenomenon, which prevents medication from having its desired effect. On the other hand, I think it's possible to propose that environmental toxicity plays a role in the production of relapse, or even from a positive perspective, in encouraging better outcomes. Evidence for this comes from a number of directions. The role of stressful life events has been frequently cited, as well as the overly intrusive, critical environment in causing relapse. The recent interest in expressed emotion, a familial interaction phenomenon, has also captured the interest of psychosocial researchers. By their definition, expressed emotion is a hostile, critical, over-involved attitude on the part of family members, parental or spousal, which in the presence of 35 hours per week of face-to-face contact produces a startling increase in patient relapse, even in the presence of active neuroleptic treatment. Both expressed emotion and affective style are amenable to change through psychosocial interventions, and this change, more importantly, has a direct bearing on outcome. In other words, if the EE changes or the affective style changes, what you find is that the outcome changes in parallel. The impact of the environment in recovery from schizophrenia appears to be as relevant as the role of the environment in the recovery from such illnesses as tuberculosis or even diabetes, or even, for that matter, recovery from the bends from diving. Did you know, for example, that recovery from the bends can be reduced significantly if there's another person with you in the decompression chamber talking to you, as opposed to recovery alone? So clearly the role of psychosocial factors, of interpersonal relationships, cannot be understated. It should be noted, and certainly in an illness like schizophrenia, we need to do more work with it. How have we done in addressing these psychosocial factors with our treatments? If we examine the available evidence on individual and group psychotherapy, we find support for a positive impact of these modalities on patient functioning that appears, except under special circumstances, to be confined to outpatient settings with patients who are either receiving neuroleptic medication or who are being treated in a system capable of preventing relapse by means of such techniques as the early intervention with medication at the first signs of relapse. Our negative impression of inpatient intensive psychotherapy comes from the major studies of individual psychotherapy conducted in the inpatient settings. The Camarillo State Hospital study, now 15 years old, is perhaps the classic in this particular field. This was a study of intensive investigation of 5 standard treatment modalities given to a sample of over 200 first admission, mid-prognosis range schizophrenics between the ages of 16 and 45 in an inpatient setting. This study attempted to evaluate treatment modalities as they could be provided in a good public treatment program. The 5 modalities were psychotherapy alone, milieu, electroconvulsive therapy, neuroleptics alone, and neuroleptics plus psychotherapy. Although the results of this study have been questioned because the therapists were relatively inexperienced and the psychotherapy was not very intense, if the study is considered as an evaluation, a management trial of a treatment as they are most likely to be employed in a standard inpatient treatment setting, then these criticisms, I think, become less potent. The investigators' frequently cited results show that the 2 drug treatments, drug alone and drug plus psychotherapy, were associated with significantly higher measures of clinical improvement than were the 2 non-drug conditions, milieu and psychotherapy alone, with ECT in the middle. The follow-up studies of discharged patients raised an additional point for consideration. Does the withholding of neuroleptic medication during the actively psychotic phase of the disorder have long-term consequences? During their follow-up period, no control was attempted over the frequency or the type of treatment received, making definitive conclusions absolutely impossible. Yet, they have reported a finding that the patients who did not receive drugs initially did spend twice as many days in the hospital after discharge as those who received drugs, raising the possibility that in a standard inpatient unit, initially treating the positive symptoms without drugs may lead to a poorer long-term course of the disorder. Again, the caveat that there was no control over the outpatient treatment part of this program should be noted. The question involved, is there a differential positive effect of intensive interpersonal psychotherapies on schizophrenic patients that is superior to that provided by supportive psychotherapy and good clinical management? The answer to that currently is no, and for those who differ with that, I think the ball is now in their court. In terms of inpatient group psychotherapy, the results are equally, if not more, sobering. It would appear that in a standard inpatient setting for the treatment of schizophrenic patients, there is little evidence to suggest that the specific psychotherapies, individual or group, when used without medication, add more than good clinical management and supportive psychotherapy. Indeed, there is some suggestion that certainly without neuroleptics, there may be potential short-term or even long-term negative effects of these therapies. Furthermore, the evidence for an additive effect of these therapies when given in combination with drugs over that of just supportive good clinical management is only modest. At a time when patients characteristically display dramatic positive symptomatology on a standard inpatient brief time unit, pharmacologic therapies are crucial in bringing about a reduction in symptoms. The amount of resources that one would devote to psychotherapy at this particular point in the treatment program, of course, should vary with any individual treatment case. But for overall programmatic considerations, it would seem fair to conclude that the exceptions need to be justified, and that beyond good clinical management, supportive psychotherapy, intensive interpersonal therapies provide little additional benefit. Psychotherapies are better suited for approaching negative symptoms of schizophrenia and positive approaches to the problems of socialization. At the time of an acute, generally time-limited hospitalization, these problems assume far less importance than does the reduction of the psychotic features of the disorder. Turning now to the outpatient studies of psychotherapy, positive symptoms which have been brought under control must be kept from reappearing. If this can be accomplished, the focus of attention then becomes those problems that prevent the schizophrenic patient from developing a meaningful, functional role in life. Two particularly thorough studies of individual and group psychotherapy have examined these points. The Hogarty-Goldberg-Schuyler studies, individual sociotherapy and medication, found that in terms of prevention of relapse, that after 24 months, 80% of placebo-treated patients had relapsed compared to 48% of drug-treated patients. Over the entire 24-month period, the addition of the individual sociotherapy produced a modest improvement in relapse. Again, the expected impact of medication on positive symptoms, or relapse as another measure of positive symptoms. Of those study patients who did not relapse in the first 6 months, however, the sociotherapy reduced relapse for the final 18 months of the study. At 18 months, for those still in the study, a positive effect of therapy on social adjustment appeared, which became much stronger by the end of the 24-month period. It should be noted that the frequency of therapy visits was relatively low, but that even at this frequency, 2 points are quite striking. The first is a toxic association of this sociotherapy with increased relapse was found early in the study on newly remitted patients not maintained on neuroleptics, and social improvement and protection from relapse for those patients who had not previously relapsed. Second study by Malm in Sweden of outpatient group psychotherapy also emphasizes this point. They evaluated the impact of group therapy when given in addition to a treatment of neuroleptic and social skills training to newly admitted schizophrenic patients. As expected, for all measures of positive symptomatology, there was dramatic improvement over the first 30 days of neuroleptic treatment for all subjects. For all patients who had not completely recovered in the first 30 days, and those that had were not included in the study, the results of the study indicated that group therapy-treated patients improved significantly more than those not treated with group therapy in the areas of social functioning, including more free time activity, entries and re-entries into social fields, and improved personal habits. No differences in relapse rates were found between the two treatment groups. The results of these two examples indicate that if we are to expect improvement from our psychotherapies, they need to be continued over an extended period of time and in And perhaps more importantly, they need to be initiated in the stabilization period after the control of positive symptomatology has been assured through whatever mechanism is available. Now, although psychiatry has traditionally based many of its psychosocial interventions on these two types of specific therapies, individual and group, there's been a growing movement over the past decade to develop treatments which are more environmentally oriented. There are certainly many therapeutic techniques to approach the environment in which the person suffering from schizophrenia lives. Training in community living programs, psychosocial rehabilitation models, family management strategies. We're particularly interested in the family therapies for the following reasons. First, over 65% of schizophrenic patients discharged from the hospital return to their families. If only patients recovering from early episodes of psychosis, when the potential for improvement was at its maximum, were considered, the figure would be much higher. Families can be a natural support system. They provide an interested, involved, and available resource which cannot be readily reproduced. Third, research has indicated that families identify potential relapse better and earlier than do patients, therefore providing an earlier indication for treatment intensification, of particular importance in those treatment strategies involving reduced medication, where the risk for incipient relapse or prodrome becomes considerably higher than those who are being maintained on standard neuroleptics. There needs to be, in those strategies, some form of monitoring that is capable of detecting when treatment intensification needs to take place. Research has indeed shown that families are quite good at identifying these early signs. Fourth, families do provide a natural setting for the context-dependent learning seemingly so essential for full recovery to take place in this patient population. Many of the failures of the token economy, social skills training, behavioral therapy approaches with schizophrenia have come through what seems to be the context-dependent learning problem, that skills taught in one setting do not necessarily transfer to a second setting. And so, for example, when social skills programs have been done in the hospital and have not followed the patient into the community, they have generally not been very successful. In working with families, however, we must also bear in mind that the family's needs must be given equal attention in the following areas. First of all, family burden. The illness of schizophrenia places a tremendous burden on the family, and the treatment program must recognize this. Early in the treatment process, families are eager to learn the kinds of skills necessary to help their family members to recover. There is an ideal point at which to intervene, and that seems to be at a point when the families are aware of the seriousness of the disorder and yet are not at a point where the burden of the disorder has become too much for them. Second, family management should be seen as a transitional strategy. Families should not be expected to become the new back wards of our treatment system. The goal of family management strategies should be to promote independent living functions. The family is an available instrument for encouraging positive change and should not be expected to play the role of chronic caregiver. Failure to recognize this essential point will lead to burnout on the part of the family, either from being asked to do too much for too long, or simply from families who become too old to provide the necessary care. Third, family management as a disguised finger-pointing. Families have become justifiably sensitive to mental health professionals who have in the past accused families of causing schizophrenia. The scars of several decades of finger-pointing are still present and certainly must be addressed early in any family management program. Although the specifics of family management strategies may vary, common among them are the following: the enlistment of the family in a positive clinical alliance, the provision of psychoeducational material about schizophrenia, the provision to the family of principles of management skills in the areas of problem solving and communication, and the encouragement to families to expand their social networks, particularly through the mutual interest groups. They tend to reduce their social networks, and there is indeed an over-involvement with the pathology in the home, both to the detriment of the family, but most specifically, as one looks at the basically two components of expressed emotion, the negativity and the over-involvement, there's also a negative impact on the patient. Finding mechanisms and means to begin expanding the social network of families is an area that I think is neglected. The self-help groups, the National Alliance for the Mentally Ill, I think do provide that. And I think they do provide a positive benefit of getting families to be more outwardly directed, to find that they're not alone in dealing with schizophrenia in their family, and taking some of that face-to-face contact, some of the intensity, and some of the over-involvement away from the family member. Family management programs have differed in their location of delivery, both home versus clinic, their mode of delivery, individual families versus multiple family groups, the timing, acute versus stabilized patients, or even whether to include the patient or not. The results, however, have not differed. They have been uniformly positive. It may not be the actual specifics or fine-tuning of many of these programs that carry the weight of whether they're effective or not. The differences in the family therapy programs are profound enough to say that there must be something general going on that is indeed quite helpful. The other aspect of them that I think is important to note is that unlike the more specific therapies, individual and group, which for some psychosis-prone patients prove to be quite overstimulating in and of themselves, there is some indication that the gains made in family management may be done with reduced levels of medication and therefore interface quite well with the new lowered dose strategies of intermittent or reduced maintenance medication. When combined with the gains in reduction of negative symptoms and the improvement in interpersonal relationships, we feel this treatment strategy will merit strong consideration in working with schizophrenic patients over the next decade. Whether what we are delivering will ultimately make a difference in the next decade will be determined by whether our research base generates better lives for the people afflicted with the illness. It's really quite simple. Until we have a better understanding of the etiologies of schizophrenia, and until our treatments are more effective, the burden of schizophrenia is going to remain. We can choose how we want to allocate it, the burden caused by this disorder. We can set priorities for it. We can even discuss it at major meetings. But we'll only be deluding ourselves if we pretend that it is not there. 2 years ago, an article in the Schizophrenia Bulletin reported on asking parents what it was like to have an adult schizophrenic child in their family. One father responded, "I wish I had some way to release my daughter from her life of continuing deterioration without the promise of cure or even any expectation of death." The same article went on to ask parents if they knew then what they knew now, would they have children again? Surprisingly, I think, the results were as follows. 17% of those parents said yes, they would have children again. 83% said if they knew then what they knew now, they would not have children again. We should remember that article when it comes to considering the creation of new back wards in the family. We can, for example, treat positive symptoms of psychosis and congratulate ourselves on a successful outcome when we return our patients to their families. But unless we reduce the number of wasted lives, I think we should be very modest about that kind of progress. For those of us who entered into the mental health profession, to add the how well to the how long of life I think we have a long way to go in schizophrenia.
This concludes the remarks of Dr. Samuel J. Keith. Please turn the cassette over for Dr. Theodore Van Putten's discussion of psychopharmacological advances and their applications in the treatment of schizophrenia. Our program continues with Dr. Theodore Van Putten, Professor of Psychiatry, University of California at Los Angeles School of Medicine. Dr. Van Putten will discuss psychopharmacological advances and their applications in the treatment of schizophrenia after this brief message from SmithKline and French Laboratories.
Oh, Grandma, I love it. Now I'll have the best costume in the school play.
Now hold still, dear. Just a few more pins in the hem and we're finished. There we go. All through.
Oh, it's perfect. Oh, thank you, Grandma. I love you.
Growing old provides the experience, skills, and special opportunity to enrich the lives of the young. But disturbed, disruptive behavior can transform a loving grandmother into a resented, unwanted family member. Stelazine, brand of trifluoperazine hydrochloride, offers a 27-year record of unsurpassed antipsychotic effectiveness with a favorable profile in the elderly. Relatively low risk of sedation, low risk of orthostatic hypotension, and low risk of anticholinergic effects make stelazine worth considering for geriatric patients. And twice-a-day dosage with distinctive blue stelazine tablets makes antipsychotic therapy easy for your patients to remember and economical for them to take.
Elderly patients should be observed closely, since they appear to be more susceptible to hypotension and neuromuscular reactions. Stelazine shares the increased risk of extrapyramidal symptoms associated with all high-potency neuroleptics. However, when encountered, these symptoms are generally readily controlled.
Stelazine, because your elderly patients with psychotic symptoms deserve the chance to feel right at home.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions, such as pseudo-Parkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. In general, dosages in the lower range are sufficient for most elderly patients. Dosage should be increased more gradually in elderly patients. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions.
Now here is Dr. Theodore Van Putten.
On the average, patients do better with drug. Everybody knows that. But what we sometimes forget, that up to 25% of patients do just as well on a placebo. And depending upon how you want to add up these things, some 25 or 30% of inpatient schizophrenics might do just as well if placed on a placebo. That being the case, how come we give everybody drug? The obvious answer is that we're totally incapable of predicting who might improve on a placebo. And furthermore, on a practical level these days, it's totally impossible to treat a schizophrenic patient without an antipsychotic drug. It just can't be done. Borders on malpractice. We have a research ward. And it's part of our research protocol that when a patient is admitted, we observe him off drug for several days, a week, or several weeks until natural improvement ceases, drug-free improvement ceases. It's absolutely remarkable, the improvement that many schizophrenics are capable of making as long as you just put them in the hospital, and you're rather nice to them, that sort of thing. If outpatients are not maintained on any drug, then they relapse at a much higher rate, 65% during the first year. And if they are on drug, the relapse rate is about 30%. During the first year, about 30 to 35% of patients or so do not relapse when they're on no drug or on a placebo. And it so happens that the ones that survive on a placebo, if anything, have a better adjustment. Again, the reason these days why we maintain all schizophrenics on antipsychotic medication is just plain and simply that we're incapable of predicting what schizophrenic can do just as well on a placebo or a no medication whatever. In our particular setting, we never treat anybody with drug until natural improvement ceases because we do plasma level and other studies. And we get regular schizophrenic admissions. There isn't anything particularly fancy about these patients. They aren't even particularly cooperative. And I'm not suggesting that you can do this in a private hospital these days. I know you can't. But an amazing amount of improvement does occur. In any event, these patients are admitted, then we put them on some psychotropic drug. At that time, 68% was just plain and simply not depressed. Then when you treat them with antipsychotic medication, 15% become depressed. Reports of post-psychotic depression have multiplied during the past 20 years. And there's sort of a murky area in psychopharmacology. I believe there are over 90 papers that address the issue of post-psychotic depression, and whether that is or is not attributable to drugs. Is there perhaps some psychotoxic drug response in at least some of those patients? That again is very complex because that 15%, there are quite a few folks in there who have what is referred to as revealed depression, i.e., these are patients that come in, they're so conceptually disorganized you can't really talk to them. And you treat them with antipsychotic medication and then they become less conceptually disorganized. You can sit down, they can talk some sense, and they tell you that they've been depressed all the time and that was really one of the things that brought them to the hospital. But they were too conceptually disorganized before to tell you about it. The usual thing, they haven't got a job, they haven't got a place to live, they're going no place in life. But that doesn't, of course, mean that it's psychodynamic. You can explain anything psychodynamically. And there's also some drug psychotoxicity there, and we'll get to that. 32% of the patients, after you observe them for a while and drug-free improvement has ceased, they stay depressed, and then when you treat these patients with drug, 45% of those depressed people improve. The message that I want to get across is that on the average, antipsychotic drugs are not bad antidepressants for schizophrenic people. Akinetic depression exists, but I don't think it's as frequent or as common as when I was looking for it very hard. I think that on the average, antipsychotic drugs are a pretty fair antidepressant for schizophrenic patients with depression. Now, what do you do if they stay depressed? It became apparent in the 70s that very high doses, horse doses of medication, were not going to cure schizophrenic people. And accordingly, there is now a movement on foot to investigate low dose, peanut dose. John Kane had a whole group of stabilized schizophrenic outpatients that were maintained on a half cc to 2 cc's of prolixin decanoate every 2 weeks, the ordinary dose that you maintain outpatient schizophrenics with. What he then did, he randomly assigned people to either that, keeping them at that dose, or assigning them to a true peanut dose, a 10% dilution, 1.25 to 5 milligrams every 2 weeks. And he compared them. The ones on the ultra-low dose did relapse at a much higher rate. To be exact, it was 58%. The ones who continued on the standard dose, they relapsed much less. To be exact, it was 8%. That, however, is still better than a placebo, and all that this study didn't have a placebo. But patients, if you were to stop the medication on that sample, you would expect a relapse rate of about 78, 75%, something like that. It was better than a placebo, but it was certainly worse in terms of relapse than the patients on the standard dose. Now, the interesting thing about this study is that the relatives of these patients, even though they relapsed more and accordingly must have given them more trouble, felt better about them. The families indicated that these patients were just more natural and more with it. In summary then, patients who are maintained outpatients on much lower doses, doses that were formerly regarded as homeopathic, do quite well. They do relapse a little bit more, but they experience considerably less dysphoria. Why might that be? Why, maybe, have we been giving schizophrenic patients too high a dose? Perhaps we're doing them a disservice. I happen to think we are. And our story is that a lot of these patients have subtle EPS which are not recorded. Now, it used to be, and it still is, that EPS was just, it was just a side effect like any other side effect. And some people even felt it was a good and useful thing. If nothing else, it certainly indicated that drug was getting into the brain, certainly into the basal ganglia. And it was even thought in the late 60s that perhaps some EPS was part and parcel of the therapeutic action of these antipsychotic drugs. And to a degree, in certain settings, they are. If you got somebody that's wild and excited and, punching, if they become a little bit akinetic and slowed up on you, that's not necessarily a bad thing. At least not for a short period of time. But there's now much more of an awareness among schizophrenia researchers that EPS is a toxic thing and that it can interfere with rehabilitation. Now, akathisia, we feel, is a rather big deal. Not only do we feel it causes a fair amount of suffering, but very often, in our experience at least, it cannot be suppressed. It's treatment refractory. As treatment goes on, the cumulative percent of patients experiencing akathisia increases such that by about day 9 or 10, close to 80% of patients have experienced akathisia. If you wait for spontaneous complaint, then you get one incidence, quite a low one. If you make general inquiry, how are you getting along, how are things, you get another incidence. Everything depends on how you collect side effect data. If you make specific inquiry, that is, if you ask the patient, how are you getting along, you having any trouble with the medication, do you feel restless or jittery inside, then you get a much higher incidence. We do ask at baseline whether patients are restless or not, and if patients complain that they're very restless at baseline, it's very difficult to diagnose akathisia. As a matter of fact, I can't do it. So it helps to ask about it at baseline. I used to think that it was not a big deal. However, we have just completed a study with volunteer medical students in which we compare Cogentin 2 milligrams BID with Simitrol amantadine 100 milligrams BID. And we test them before and after 3 days in active medication, which very sophisticated memory tests. It develops that a substantial minority of these medical students are really cognitively impaired on the Cogentin 2 milligrams BID. It's extraordinary. I didn't expect to find this, but it's absolutely true. They feel spacey, they can't concentrate, they have much more trouble with these memory tests. And now that I'm sensitized to this issue, I've noticed it's not unusual that you have a schizophrenic who's quite toxic on his anti-Parkinson meds. I have to run an outpatient clinic every week for schizophrenic patients. I decided I'd ask everyone how their memory was, and nearly all to a man they replied that it was lousy. So I'm beginning to think that we need to look more closely at putting everybody on Cogentin or Artane. The considerable amount of vague complaints of tension and anxiety in schizophrenic patients is akathisia-based. And we can't prove that because we haven't the technology to really measure akathisia. You got to use these rating scales and clinical questions. And you can have inter-rater reliability, but that doesn't mean much. You can teach two fools to think alike. Rifkin, Quitkin, and Klein look at akinesia as a behavioral state. We're not talking here about severe akinesia, the zombie reaction. Milder akinesia. It is evident as a behavioral state characterized by diminished spontaneity, few gestures, unspontaneous speech, apathy, and difficulty with initiating usual activities. Those symptoms are exactly the same as the negative symptoms of schizophrenia, right? Sitting around, doing nothing, no drive, flattening of affect, etc. So you ask, how well do I distinguish between the negative symptoms of schizophrenia and the akinesia, and the answer is very poorly. As a matter of fact, a good part of the time, on a one-shot basis, I can't do it. And I'm not so sure that anybody can. Patients, for some reason, do not complain of akinesia. They hardly ever do. It's not clear to me why. But if it does creep up in the conversation, they say things like, I feel listless, I feel blah. All I want to do is sit or lie down. I do everything slowly. That sort of thing. The usual story, of course, is that what happens in life, that milder akinesia is superimposed upon the negative symptoms of schizophrenia. In our clinic, we have reduced medication on board in care populations, and I'm not going to tell you that it cures these people, but they do become more lively, more active, they sleep less, they participate more in things like bingo games, they go to the movies more. And I certainly think at times with younger schizophrenics, first admission, first break schizophrenics, I think it can make a vast difference recognizing this. When I say that I recognize this poorly, or that I distinguish poorly between this and negative symptoms of schizophrenia, I saw some time ago a young woman, a professional parent, both parents were lawyers. She was on a very low dose of medication. Things weren't going that well. She didn't have any positive symptoms, but there was sort of some habits, some personality deterioration. She would be a receptionist in her parents' law firm, and I don't know, there wasn't anything going on. She'd flop on the couch, and sort of sack out type thing. And she used to laugh a lot. She did less of that. And she used to like to play baseball a lot. She was sort of a tomboy, and she stopped doing that and just didn't talk much type thing. And I really didn't know whether that was akinesia or whether that was more negative symptoms of schizophrenia setting in. In any event, we stopped the Navain, and over the next several weeks, she became progressively better. Became more with it, more active, started laughing again, didn't flop down on the couch, everything was much better. And at that time, we thought that perhaps we would try Carpenter's strategy of intermittent medication. And we just watched the girl, and parents were very understanding, very sympathetic. She relapsed within 36 hours. Police had to be called, and it took some 7 or 8 months in order to stitch her back together again with antipsychotic medication. I'll never forget that particular case. I don't think this young woman is anywhere near as well as she was before that second break. And in our hands, at least, the idea of intermittent antipsychotic medication, sort of intellectually sound and appealing as it is, don't work, or at least we regard it as dangerous. We think that the low-dose strategy is much better. Now again, with akinesia, the reason why we can't prove our stuff is because you can't really measure it. But I think that the test questions to ask are, do you feel stiff? Do you feel slowed up? Do your muscles ache or hurt? Neurologists will tell you that one of the earlier symptoms of Parkinson's disease is joint pain. Do your joints hurt, and how much do you sleep? We think that amount of sleep time is the closest correlate of akinesia. When you have a schizophrenic that starts sleeping on you 10, 12 hours a day, that one of the first things to think about is akinesia. It need not be that. It can be withdrawal sleeping type thing. Or sleeping perhaps due to lack of stimulation in the environment. But when you see these patients that don't gesture and they don't have all that much expression in their face, they don't make the ordinary shifts of posture as they sit in the chair, that may well be akinesia, which has all sorts of mental manifestations. We think that EPS is really at the bottom of many dysphoric responders. These patients, they hate medicine, they don't want to take it, they're allergic to it, they can't stand it, they easily get into adversary relationships with staff. We think these patients, who are of course a problem to everybody, can be managed, and at times you can get a decent outcome by using very low doses of antipsychotic medication. And at times, they do reasonably well on that. These patients with dysphoric responders, we have an interest in that. And we have wondered if you could just keep these people on medication, do they eventually have a good outcome? Or is there really something to what they say? The medicine makes me feel worse, makes me hallucinate more, and all that sort of thing. In other words, are these the meanderings of a sick mind, or might they really know at some level what they're talking about? There are some schizophrenics, indeed, where the drug does seem to make them depressed. They sleep too much, they're emotionally withdrawn, they're disinclined to speak, they're wooden in appearance, they're motorically inactive or retarded, they lack initiative, and they experience overwhelming fatigue. It's exactly the same symptoms as drug-induced akinesia. We think that some post-psychotic depression is really akinetic depression. I have no idea what percentage. It certainly depends upon the dosage of antipsychotic drug that people customarily use. I would imagine that in units in which you use rather high doses of antipsychotic drug, after the second week of inpatient treatment, that a fair amount of post-psychotic depression is probably drug-based, or at least drug contributes to it. A lot of relapse in schizophrenia is due to non-compliance. And every clinician, I think, has in his mind's eye the schizophrenic patient that comes every month to the clinic and they get their medication and they stay out of the hospital. So we figured that if schizophrenic patients keep taking their medicine, then of course they wouldn't relapse. And therefore, in the clinician's mind, and I very much include myself, when patients relapse, that of course must mean that they aren't taking their medication. What we have to expect in today's world, in today's society, about 30 to 40% of schizophrenic patients will relapse the first year out of hospital. That's a disturbing figure. In this society, that's a fierce problem. I don't particularly like doing family therapy, but I've really become to believe that it's important. That if you have families that you discharge a schizophrenic to a family that's high in expressed emotion, meaning that they yell at them and are critical and call them lazy, and where the negative symptoms of schizophrenia leave off and where laziness starts, only God knows. So when you have families that are high in expressed emotion and intrusive, if you give them family therapy, which as I understand it is mostly a psychoeducational matter, that it really appears to work. It really reduces those relapse rates. And this is with some social skills training thrown in. Social skills training just by itself, I don't know how effective that is, too early to tell, but there's definitely something to this family therapy business. There is currently some thought, and I believe in it myself, but I do not know it's correct. It certainly hasn't been demonstrated, that maybe our treatment of schizophrenic patients is in great part wrong. Because, you see, after that first year, the relapse rates of schizophrenic patients drop markedly, drops down to about 8 to 10%. So maybe the thing is, we're beginning to think, that maybe you should just survive that first 9 to 10 months out of the hospital. And maybe we shouldn't push all these rehabilitative strategies on people. Maybe it's just good enough if you stay out of the hospital, and maybe we should tell parents more that, well, you know, he hasn't got much energy and sleeps a lot, and okay, so he's only taking one course, or at this time he doesn't want to take any courses. Maybe that's all right. Maybe it really takes much longer than we think to get over a schizophrenic relapse. I'm not sure that that strategy is going to pay off, but I don't know, it feels good to me, and at least in my practice and consultations with parents, I've been influenced by that thinking. Oh, it's something for you to think about. Maybe we should lower our expectations the first year out of hospital. Lower dose is something to think about. Although I'm not at all sure that a plasma level tells you anything all that useful yet, I think what will come out of the plasma level research is that there is such a thing as psychotoxicity at higher plasma levels and higher doses, and that sometimes lowering the dose is really a winner. Environmental psychotoxicity is also something to think about. I think of a Atascadero State Hospital where I see patients that they are so autistic. They don't eat, horrible, messy, filthy, impossible. It really looks like they pay no attention to the environment, whatever. They're just 100% autistic, and they've tried everything. So at times, you get a move to another ward for one reason or another, like the medical ward, they injure themselves. It makes the most incredible difference. I've been impressed with that over the years, and certainly in these state institution type environments, something to think about. I guess perhaps sometimes funny things develop between a caretaker and these severely ill patients. The last treatment is benzodiazepines. There's not much literature on it. There are some case reports, letters by I think thoughtful people, that sometimes benzodiazepines in reasonably ordinary doses, Valium, diazepam, 10 to 20, 30 milligrams a day, are surprisingly effective. And in some people, at least according to these case reports, even seem to have some antipsychotic effect. How much antipsychotic effect they have, I'm not entirely certain about. But I think that it's not that unusual that a schizophrenic patient feels much better when some benzodiazepines, some Ativan, some Valium is added. And I commend it to you as something to think about. There is this notion of supersensitivity psychosis. I just mention it because I think you ought to know about it. Nobody knows if it exists. I personally don't believe that there is such a thing as supersensitivity psychosis, or if there is, I believe that it is extraordinarily rare. The thinking is that there is, everybody knows there's such a thing as tardive dyskinesia, and if there is such a thing as tardive dyskinesia, which is presumed to be dopaminergic hypersensitivity in the basal ganglia, then why shouldn't there be a dopaminergic hypersensitivity in the limbic system, where presumably these antipsychotic drugs act to deliver their antipsychotic effect? What that would mean, if you think about it, is that after you give a patient an antipsychotic drug over the years, that part of their psychosis might perhaps be a supersensitivity psychosis. Maybe you get new psychotic symptoms, just like some people develop tardive dyskinesia. Of course, you've ruled out that, there might be some chance that they do better maybe on Tegretol, but, you've ruled all that out, and they need some neuroleptic drug, and what are you going to give them? If you have a schizophrenic patient like that and you love them an awful lot, you could put them on clozapine, which, as you may know, causes no EPS. It's a drug, it's called anafranil. That's used quite a bit in Russia. It's quite popular in South America. To my knowledge, it has not really been demonstrated that clozapine would be the best drug, but it certainly makes sense because it really causes no EPS except perhaps an occasional akathisia. And there are indeed papers that demonstrate that if you give clozapine to patients who have difficulty with EPS, it's a superior neuroleptic. I think that antidepressants, too, are much underutilized in schizophrenic patients. There is this scuttlebutt that if you give a schizophrenic patient antidepressants, they'll get worse on you, which is true if they're not on a neuroleptic. But if they're on a neuroleptic and you add an antidepressant, that's not true. And Cyrus in New York at Mount Sinai Hospital has recently done an elegant study in which he compared patients who certainly appeared to have a post-psychotic depression, were stabilized on antipsychotic drug. The other thing that I might recommend for depressed schizophrenics, what we do, we just admit them to the hospital, and we don't really do anything special, to tell you the truth. We're just rather nice to them, sort of really nothing. We're just nice. And they improve remarkably over a week or two or three. Most of the time we change nothing. We're actually interested in studying it, but by the time, we finish being nice to them, they're no longer depressed, the vast majority of them.
This concludes our premiere program in the 1986 SK&F Psychiatry Audio Cassette Library Series, Update on Schizophrenia. Featured on this program were Dr. Samuel J. Keith and Dr. Theodore Van Putten. This program was recorded on location at the 7th Annual Vail Conference of the Menninger Foundation. SmithKline & French Laboratories sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing medical education program. The views expressed here are those of the individual physicians. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was produced by SmithKline & French Laboratories and SK&F Co.